Good morning, everyone. My name is Hani Najm. I'd like to welcome you to our 7th annual Advances in Congenital Heart Disease Summit with a theme this year on transposition of great arteries, a master's class. It's been really a great journey since we started this 7 years ago at the Cleveland Clinic. And it's a delight to be back in person to see all of you. We've had a caveat of 2 years where we're not able to see each other. We were seeing each other through a small screen. So we'll come back to sunny Florida here today. This year is the first year that we do it in Orlando. And the reason why we're doing it in Orlando is because we're collaborating with the University of Florida. So it's Cleveland Clinic, as well as Akron Children and University of Florida is collaborating in this meeting. So on behalf of myself, Dr. Brad Marino, my colleague, Chair of Pediatric Cardiology, and Dr. Jeff Jacobs, and Mark Bleiwitz, we would like to welcome you to this meeting. As you've seen from the agenda, we've invited an incredible number of amazing faculty that will talk and have a deep dive onto the transposition of great arteries. From anatomy to simple surgery to complex surgery to complications after surgery, early in the ICU and later on in life. So this would be really for addressed to both younger and early career as well as advanced people in this field. So I'm also delighted to report that we've had a nice registration mix from all over the world. Can I have the next slide, please? Yeah. So we have actually a show up of 36 countries represented in this meeting. And I'll leave this slide a bit to see the magnitude of spread of this meeting. So between in-person and virtual registration. So I really want to thank all the faculty who have traveled from different parts of the United States or different parts of the world to come and join us for this meeting. So these are the world representation of the countries, and this is the states representation within the United States. So I'd like to welcome all of you for this. This is a nice really show for a transposition of great arteries. Also, I'd like to thank our sponsors in the Florida Ballroom, Abbott Laboratories, Edwards Life Sciences at the Roll Track, as well as guarantors, Berlin Heart, Edward Life Sciences, Livanova, and Stratasys. The usual housekeeping notes, please keep your phones on silence. And I would like to encourage the discussions after each session. We have a panel discussion. Please don't hesitate to come up and ask questions. Please join us also today. There's lunch will be served in the room next door, as well as there will be a Jeopardy, which is going to be a lot of fun towards the end of the day. So come at the end of the day around 5:30, right after the sessions, we'll have a Jeopardy session. We'll have 3 teams and nice fun time for an hour or so prior to dinner. Tomorrow also, there is a reception for the abstracts in Marco Island. This will be followed by dinner and the fireside chat between the chairman of Heart and Vascular Institute at the Cleveland Clinic, Dr. Lars Svensson, and Colleen Cook in the same venue there. So we look forward for that also. It's going to be a nice dinner and to elaborate the highlights between Cleveland Clinic and University of Florida. This meeting is also accredited for CME. Claiming the hours would be right after the meeting when it's done. I'd like also to announce that we will have an adult congenital conference that is happening in the end of March. It's comprehensive care for the lifetime treatment of adults with congenital heart disease, a case-based approach. It's going to be also in Chicago, and you're most welcome to come. The brochure is outside. You can pick that up. Again, welcome all of you on behalf of Dr. Brad Marino, Hani Najm, and Jeff Jacobs and Mark Bleiwitz. Thank you so much again for coming in, and look forward for an active participation. And I'd like to invite Jeff Jacobs to introduce our patient experience. There's nothing better than having a patient who have gone through some interventions for congenital heart disease and to see them many, many years after life. This has always been for us when we sit around in the morning and plan the treatment course. This is what we want to see. We want to see the final product. This is how we should design our surgeries to be, where we can have a very productive life. So we're all excited to hear from you, Matthew, and I'd like to invite Jeff to introduce Matthew. Thank you.
Well, good morning, everybody. And first, thank you, Hani. I'd like to thank our collaborators and partners at the Cleveland Clinic with Brad Marino and Hani Najm in the front row, and also Samantha Pringle, who's organized and put all of this together and dealt with a variety of logistics. This is the first collaborative meeting between University of Florida and the Cleveland Clinic, and we're planning on making this an annual collaboration and hopefully meeting around the time of President's Weekend every February during Heart Month, and establishing a real solid collaboration between Cleveland and UF with a meeting that I think is going to grow and grow and grow. I'd also like to apologize for my partner, Mark Bleiwitz, who cannot be here today. His mother died, and unfortunately, he's unable to travel at the moment because he's back home spending time with his family, as he should be. Mark and I spoke yesterday. We spoke today, and he wishes he could be here. I'll be presenting his lectures today, and we've been going back and forth getting all the slides shined up for those talks. So again, he apologizes that he cannot be here, but he's been a critical component of getting this whole meeting and organized and assembled and put together, and he's sorry he can't join us. As Hani said, we're starting out the meeting with a talk of a patient experience, and this is actually one of Dr. Bleiwitz's patients. And I'll say a few things about Matt Purley, but he's going to tell his own story a lot better than I can. Matt's an undergraduate student at University of Florida. He's taking a gap year doing research at the Congenital Heart Center with Mark Bleiwitz and all of our cardiologists and the cardiac surgeons. He's being mentored quite closely by Yuri Stukov, who's recently joined our faculty as well, who's a congenital cardiac surgeon from the Ukraine. And Matthew has really done an incredible amount of work on a number of academic activities within the Congenital Heart Center over the past year in preparation for starting medical school. And importantly, his story is a unique story of why we do what we do. And rather than tell you more details, I'm just going to have Matt come up. He's going to tell his story. He's a rising superstar. He's going to be a physician. He's going to go to medical school, and he's going to do great things. But the pathway that he traveled to get to this point is really a story of why all of us get up in the morning and go to the hospital. And with that, I ask everybody to give Matt Purley a round of applause, and he's going to come up and tell his story.
Good morning, everyone. First of all, I'd like to say I'm honored to have the opportunity to come speak at the 7th Annual Advances in Congenital Heart Disease Summit. As Dr. Jacobs said, my name is Matthew Purley, and I'm a research assistant with the University of Florida Congenital Heart Center, and I'm currently in a gap year as I prepare to apply for medical school. But most importantly for this presentation, I'm an adult congenital heart patient with repaired transposition of the great arteries. I'm very excited to be here today and have the opportunity to share my story of living with this condition and talk about how it's challenged me, but how it's also inspired me to pursue a career in medicine. Now, before telling my story, I think it's important to reflect on the history of how transposition was treated in the past. A little over 70 years ago, there was a time when no reliable surgical intervention existed for patients born with transposition. For these patients, unfortunately, little could be done to fix the anatomical defect that they were born with. And unfortunately, as a result, most of these patients, as many as 90%, died before their first birthday. Now, the first surgery designed to correct transposition was known as the atrial switch. It was first performed in 1957 by Dr. Ake Senning and subsequently modified by Dr. William Mustard in 1963. Now, this procedure involves creating a baffle for blood to flow between the sides of the heart, which can be seen on this picture here. And this creates atrioventricular discordance. Now, when you combine that with the arterioventricular discordance that defines dextrotransposition of the great arteries, it actually results in physiologically corrected blood flow. And what I mean by this is it allows for the correct sequence of blood collection in the atria, subsequent oxygenation by the lungs, and then systemic circulation through what is now a systemic right ventricle. And nowadays, of course, we know that despite excellent short-term results, the atrial switch operation can lead to complications such as dysfunction of that systemic right ventricle, as well as arrhythmias that may require pacemakers or further intervention. Following the atrial switch operation was the development of the arterial switch operation, which is now most commonly used to repair patients that are born with dextrotransposition of the great arteries. The arterial switch operation involves dissecting both the pulmonary artery, and aorta at their respective roots and reattaching each artery to the other's native root. Coronary artery buttons must also be cut, and these will be reimplanted after the quote-unquote arterial switch has occurred. Now, the arterial switch operation is not without its long-term consequences, as we've seen recently, chief among them being neo-aortic root dilation, as well as pulmonary hypertension. But in most cases, the short and long-term results of the arterial switch do tend to be superior to the atrial switch. And while the arterial switch was not a new idea in 1975, people had thought about it before they understood the anatomical defect. The first surgeon to successfully perform the operation was Dr. Deep Jatin, to whom the procedure now owes its name. So you may hear it referred to as the Jatin procedure or the Jatin operation as well. So now that I've reviewed the history of DTGA and its surgical intervention, I'd like to just give a brief account of my experience living and growing up with transposition. So I was born November 3rd, 2000. This is about 10 years after the arterial switch became the preferred method to treat dextrotransposition of the great arteries. As best as I know, this is just according to my mom, no one suspected I had a congenital heart defect when I was born. It was only after a couple hours when some nurses were giving me a bath and they noticed a blue tint in the corner of my lips and my fingernails that they thought something might be wrong. So after a battery of tests and imaging, it was discovered that I was born with transposition. Now, after having a week to stabilize, I had an arterial switch operation as done by Dr. Mark Bleiweiss. The operation was a success. There were no complications. And 17 days later, I was discharged home to my family, happy and healthy. Now, growing up with congenital heart disease, even in my situation where it was repaired and I was by and large healthy, it meant frequent trips to the cardiologist, which as a young child was scary and uncomfortable. There were tests being run on me that I didn't understand. And I'm going on a limb here, assuming that many of you haven't had an echocardiogram. So you're just going to have to trust me when I say that after about 30 to 40 minutes of having an echo probe stuck in your chest, it does tend to get uncomfortable. But I grew up and I matured a little bit. And as I got older, I began to appreciate both the knowledge and the expertise that these doctors and these healthcare professionals had, and how hard they worked to monitor my disease and keep me healthy and make sure that I could go out into the world and live my best life. And part of living that best life was playing sports. From a young age, I was cleared to play sports, and I played soccer, basketball. I ran cross country in high school. And I consider this a very important part of when I was growing up, because as a congenital heart patient, I think it's important that we're able to define ourselves beyond just our disease and possibly our limitations. And so having the opportunity to play sports and be like other kids that didn't have defects or something like that, that was a very important experience for me growing up, and being able to define myself in a way other than just my condition. And of course, a silver lining for me of being a congenital heart patient was growing up and being around doctors all the time. I grew accustomed to medicine, and I do think that that early exposure to medicine and having to learn so much about my body at such a young age, it really sowed the seeds for wanting to pursue a career in medicine, which is now obviously what I'm actively doing. So I want to fast forward a little bit to 2021. I was a junior in college at this point, and I knew enough about cardiology from shadowing doctors, as well as, of course, my own experiences as a patient. But I wanted to see what it looked like from the surgical perspective. I wanted to see, how do you manage a patient that's so young and so sick, and how do you get them through such a serious operation and make sure that they're able to go home happy and healthy to their family like I was able to. And so I knew who Dr. Bleiweiss was. Of course, I didn't remember him, because the last time we had met, I was about this tall and a week old. So I reached out to him and I emailed him and I reintroduced myself and expressed interest in coming and shadowing him and his surgical team at the University of Florida. And as luck would have it, he saw my email and he remembered who I was. And so I got in touch with the department and I figured out some dates to come down and shadow. And as it turned out, I spent most of the summer of 2021 at the University of Florida Congenital Heart Center, shadowing Dr. Bleiweiss, Dr. Jacobs, Dr. Peak, and the surgical team. And for me, it was really a life-changing experience. I knew at this point that my heart was set on medicine, no pun intended. But for me to be able to watch the surgeon that had saved my life do the same for other people was really a watershed moment for me, because I knew deep down that so many of these patients that had had these life-saving operations would now go out into the world and grow up and have the opportunity to write their own stories the same way that I've written mine. And that brings us to today. Right now, I'm currently working as a research assistant with the University of Florida Congenital Heart Center. This opportunity has given me an ability to continue to learn about my interest in medicine, and especially congenital heart surgery specifically. And I've learned some of the research aspects of how to design and implement effective research protocols and how to analyze data from those said research protocols. And I could talk to all of you at length about so many experiences that I've had, but I think there's one experience that ties up this story of my experience with transposition in a nice, neat bow. You see, remember that Dr. Adib Jatin was the surgeon who originally performed the arterial switch way back in 1975. It's the same life-saving operation that I received in 2000. And it just so happens that Dr. Jatin's grandson, Dr. Ottavio Jatin, came to Gainesville for a couple weeks this past September. I had the opportunity to introduce myself, to get to know him, and I would consider ourselves friends. Here's a picture when he was his last night in Gainesville. We were sharing a cup of sake. And for me, this is just a story I love to share. I think it speaks to the power of this field, not only to save lives, but to bring people together. And for me, this is about as full circle as you can get. So to conclude, I wanted to make just 2 points that I hope came through in my presentation today. One of which being is, though I'm here telling you about my story, there are so many people nowadays that can share a similar story. Congenital heart surgery in the past 50 to 67 years has had such rapid advancement that the patients now in the modern era can go out in the world and mostly live normal and happy and healthy lives. And I think it speaks to the spirit of research and innovation and improvement and chasing improvement for patient outcomes that I think has pervaded the field since its inception. And secondly, it's that same spirit of research and innovation and continuing to improve outcomes for your patients, which I'm sure we'll see on display in the next couple days, that in my opinion ensures a very bright future for congenital heart surgery and the field itself and its outcomes. And it's going to allow the field to thrive just as much as the patients that it serves. Last but not least, I just want to take a moment to give special thanks to Dr. Mark Bleiweiss, who unfortunately couldn't be here, Dr. Jeffrey Jacobs, Dr. Giles Peak, and Dr. Yuri Stukov. They've been invaluable mentors for me. They've given me so much guidance. And without them, I quite literally would not be here standing and having the opportunity to speak to you today. Thank you.
I think that's a powerful way to start this meeting. It really tells us why we do what we do every day. I know I've been texting with Mark Bleiweiss, who was able to watch this on the Zoom link. And Mark just texted me to say, Matt, congratulations, great talk. He's completely emotional and speechless. So thanks for delivering that. And Bleiweiss was watching and he's happy and proud of you. That's a great way to start this meeting. I'll ask the moderators of our first session to come up and we'll dive into the science. Later today, when you walk around the posters, we'll be able to see that one of those posters is young future Dr. Matt Perley's poster. So stop by and see that, and you can look at the science he's doing as well. And I'll turn it over to Brad Marino, Dave Cooper, and Jen Kovu to start the first session. Thank you.
Good morning, everyone. Before we start, I just also want to extend my welcome to all of you. We're so excited to work with the University of Florida and to have all of you here in person. It's been a long time since we were able to do this, and it's really special. I just want to thank Matt. That's hard to do. And I was thinking about 2000 when I was a fellow at Children's Hospital Philadelphia and the dozens of babies we did the arterial switch operation on. And to see you now here 23 years later, doing the great work you're doing at University of Florida with the team there is just incredible. Great work. I will have my other moderators introduce themselves.
Hi, I'm Jennifer Kovu. I'm one of the pediatric cardiologists at University of Florida, and I am the director of the fetal cardiac program and also the single ventricle program.
I am David Cooper. I am at Cincinnati Children's Hospital, where I'm the medical director of the Heart Institute and of the Cardiac Intensive Care Unit. Oh, me first?
Oh.
No.
Oh, you're first.
Yes. All right. Hi. So I think we will start our session, and our session will be on transposition of great arteries and abnormal coronary arteries. And we will start the session with a case presentation. The case presentation will be given by the University of Florida Congenital Heart Center first-year fellow, Juan Loyao Lung. And she will present a case on a patient with abnormal coronary arteries. Juan?
I'm a first-year pediatric cardiology fellow in the University of Florida, and we will start this session with a case presentation of a patient with TGA and abnormal coronaries. We will go through the perinatal course of the patient, the diagnostic images, surgical findings and interventions, and the outcome of the patient. So our patient was a full-term 37-weeker male born to a 27-year-old mom, D2P0, that had an uneventful pregnancy, negative serologies, and normal OB ultrasounds. The delivery was also uncomplicated. The birth weight was 3.9 kilos, and he was admitted to the newborn nursery afterwards. On date of flight 1, patient started to have respiratory distress, cyanosis, the saturations were in the 70s, and during the physical exam, patient was noticed to have a murmur, and a transthoracic echocardiogram was ordered. This showed DTGA with single right coronary, a VSD, PFO, and a small PDA. As we can see on the left side of the screen, we can see a 4-chamber apical view. When we sweeping anteriorly, we can see that there's a ventricular arterial discordance, and the great vessels are side by side. We can see that from the right ventricle is giving the aorta, and the left ventricle is giving to the pulmonary arteries. Going to a peristernal long axis, we can see that the aorta is anterior to the pulmonary artery. And when we add in color, we see that the aorta does not have any insufficiency or stenosis, and there's just trivial pulmonary valve insufficiency, and there's no stenosis. On our peristernal short axis, we can see that the aorta is anterior and rightward to the pulmonary artery. And continuing on our peristernal short axis, we can see that from the posterior right sinus is giving one single coronary that then divides to the right coronary artery and the left coronary artery that seems to go behind the pulmonary artery. In this study, it was did not reveal that there was any coronary arteries coming from the left side of the posterior sinus. And this is the still image showing the same. Going back to our 4th chamber, we can see that there was a moderate side VSD. And from a subcostal view, we can see that there was a PFO that at that time showed that it was unrestricted flow from right to left. Due to all these findings, patient was started on PDE. It was at 0.05 micrograms per kilo per minute, and then the patient was intubated. And on date of flight 2, patient started showing signs of poor intracardial mixing. His saturations were in the 40s, his NIRS were in the 30s, and a bedside balloon atrial septostomy was performed. Patient did well after this procedure. He was hemodynamically stable, was able to be extubated, and maintained his saturations in the 90s. He was weaned off of PDE prior to surgery. Our patients usually go from pre-op screenings with head ultrasound, head MRI, and abdominal ultrasound that were normal, and his genetic workup was also negative. During the intraoperative course, the findings during the surgery was the TGA, and actually patient did have 2 coronary arteries. From the right-hand side sinus, it was shown that there was a large branch that then divided to the right coronary artery and then divided to the left coronary artery that then went to be a circumflex and a left anterior descending. But it was all noticed that from the left hand sinus, it was having a moderate sized conal branch. Other findings were a VSD with core straddling to the septum, PFO, and a small PDA. Patient underwent an arterial switch procedure. The right-sided and left-sided coronary buttons were harvested correctly, and then there was transfer using medially based flap. There was also patch closure to the muscular ventricle septal defect and suture closure of the PFO, and then division of the PDA. The surgery did not have any complications. Patient came back to our unit, the cardiac ICU, intubated on Mirinone, epinephrine, and calcium chloride drips, and did have some junction ectopic tachycardia that was terminated with atrial pacing. Afterward, patient was extubated and weaned off inotropes, and it was transitioned to oral medications, tolerated feeds, and was discharged home at date of post-update 8. Patient's currently 8 years old. He's been doing well. He's not on any cardiac medications. He follows annually in our clinic. In our last echocardiogram, there's good biventricular function. There's no significant aortic dilation, and there's no insufficiency.
Next up, we'll invite Diane Spicer to the podium. So I've had the privilege of knowing Diane for a long time now. She's an internationally renowned cardiac morphologist who currently works at both Johns Hopkins All Children's Hospital in St. Petersburg and the University of Florida Congenital Heart Center in Gainesville. And she'll talk to us about the anatomy of transposition and abnormal coronary arteries. Diane.
Thank you. Thanks to Jeff and Mark and Hani and Brad for inviting me to participate in this meeting. Just as a quick review, we all know that the most significant feature of transposition is discordant ventricular arterial connections, and that means that the aorta comes from the morphologically right ventricle and the pulmonary trunk from the morphologically left ventricle. It's important to remember that ventricular origin of the arterial trunks, relationships of the arterial trunks to one another, and infundibular morphology are all mutually independent features. And separating the above features in a descriptive fashion takes away from any confusion or controversy that we might have discussing these cases between clinicians and surgeons and echocardiographers. Transposition has two major groups, those without any major complicating lesions, which we typically refer to as simple transposition, and those with malformations that sufficiently can complicate the clinical picture. It's also important to remember that simple transposition can have its own complicating issues like premature closure of the oval foramen or coronary artery abnormalities. These complicating lesions are listed here, but for this session, we're going to focus on coronary artery anatomy. It's important to describe the position of the aorta relative to the pulmonary trunk, and it's also important to realize that as these arterial trunks arise from the ventricular mass in different positions related to one another, this can also affect the coronary artery anatomy. So you can see from left to right, I have the aorta anterior and rightward of the pulmonary trunk, the aorta directly anterior to the pulmonary trunk, anterior and leftward of the pulmonary trunk, and rightward and side by side. And you'll note in the two right-hand images that the coronary arteries cross in front of the arterial pedicle. In the anterior and leftward, it's the right coronary artery in front of the pulmonary trunk. And in the rightward and side by side, both the right and the anterior interventricular arteries arise from that right-hand facing sinus, both crossing in front of an arterial pedicle. Coronary arteries arise from the sinuses adjacent to or facing the pulmonary trunk, and we'll look at what is known as the Leiden convention in a moment. It's important to look at the epicardial course because they are much less predictive than where the coronary arteries arise from the sinuses. It's best to describe all of these multiple variations that we can see and take note of the origin of the three main coronary arteries from the aortic sinuses and their course relative to the vascular pedicles. It's also important to pay attention to the fact that if there is an intramural course, which makes moving those coronary arteries in the arterial switch much more difficult. It's also important to look at the origin of the artery to the sinus node, because if that artery extends over the anterior aspect of the right atrial appendage, this could cause quite significant surgical complications. And also to look at commissural mismatch, but I think at this day and age, surgeons don't worry too much about that at this point. The Leiden Convention is such that it allows the observer to identify the position of the coronary arteries relative to the pulmonary trunk. And the first image I'm going to show you is in the normal heart, where we have concordant ventricular arterial connections. So the observer is standing in the aortic valvar sinus that's farthest away from the pulmonary trunk or the non-adjacent sinus. And you can see that the right hand of the observer is facing the right hand facing sinus, or what typically is called sinus number 1, and that gives rise to the right coronary artery, while the left hand of the observer is facing the left hand facing sinus, or sinus number 2, and that gives rise to the left coronary artery. With transposition, this is actually, when you think about it simply, is transposed. So the observer is now standing in the non-adjacent sinus of the aortic valve relative to the pulmonary trunk. And you'll note that the observer's back is to us, so that now the right hand facing sinus gives rise to the left coronary artery, and the left hand facing sinus gives rise to the right hand coronary artery. And this is an easy way to describe the coronary artery position. I know it doesn't work well for echocardiographers, and I know probably every person in this room, surgeons included, have their own way of describing these, but it's just a good way, a basic way to look at the position of the coronary arteries. We also need to consider commissural mismatch, and you can see I have marked here where the zones of apposition of the arterial valve and the pulmonary valve join the pulmonary root, and the comparison where the commissures, or the zones of apposition, join the aortic root. And you can see that they don't match up in this particular heart. Typically, this yellow dot would be immediately adjacent to this red dot between the pulmonary artery and the aortic root. So this can cause an issue when coronary arteries have to be moved during the arterial switch procedure. And also, it's important to note the origin of the sinus node artery. In this case, it arises from the right coronary artery. Coronary arteries typically arise within the aortic sinuses at the level of the sinutubular junction, and they're usually eccentric within the sinuses. You can have a high origin or a low origin. Coronary arteries with a high origin are typically well above the sinutubular junction, 4 millimeters or more. I have seen relatively normal origin slightly above the sinutubular junction. Low origin, they can arise deep within the aortic sinuses. It's important to note where the aortic or where the orifices are located. Are they coming from the same sinus? And you'll see I have in parentheses both orifices or 2 orifices. And that's meaning that you can have all 3 of the main coronary arteries with their own orifice. So you have to identify where all of the orifices are coming from. Also, we can have a single coronary artery, and these can take multiple different courses as well relative to the arterial pedicles. The intramural course is an important consideration because the coronary artery will cross the attachment of the valvar leaflets at or below the sinutubular junction. And this makes it difficult to move these coronaries, as the arterial valve will be affected once that coronary button is removed. Epicardial course is also important because you can have these arteries extending retropulmonary or anterior to the aorta. I have a number of examples of some of these abnormalities that we can see, just so you can get a feel for how different these things occur. This one shows us both orifices from the same sinus, sinus number 1. So you can see that the aorta is supported by a complete muscular infundibulum. And there you have the right coronary artery and the left coronary artery, which also arises quite close to one of those commissures. Here we have the right coronary artery from sinus number 1, and it crosses in front of the aorta, and then the anterior interventricular and the circumflex artery arise from sinus number 2. So you can see the anterior interventricular artery passing behind this pulmonary trunk, which this patient also had a pulmonary artery band. And then you can see that the left main coronary artery has a quite long segment with the circumflex and the anterior interventricular branching from that long segment posterior to the pulmonary pedicle. Here is a single coronary artery with the single coronary arising from sinus number 2. Here you can see the right coronary artery. There's a very short common segment. There's the sinus node artery that was bisected during dissection. And there's a significantly long segment of the left main coronary artery segment that then bifurcates into the circumflex and the anterior interventricular branch. Also, this patient has quite a long and large infundibular branch extending anterior to the aorta. This is a single coronary artery from sinus number 1, or the right-hand facing sinus, and you can see the right coronary crossing in front of the aorta, and then the anterior interventricular and the circumflex branch, again, arising from a quite long segment of the left main coronary from that single orifice. This is a short axis of a specimen that actually was dissected a bit too low, but I'm fortunate to have all of Dr. Van Meerop's old autopsy reports, so I'm able to confirm that this specimen did have a single coronary artery that arose between the arterial trunks, and there was a segment of the right coronary artery that was cut away during dissection, as well as part of the commissure, where the left coronary artery had a short intramural course. You can see the aortic valvar sinuses where they join the aortic root, or I should say the commissures where they join the aortic root, and note that this patient also has commissural mismatch. This is another interesting case with a single coronary artery from the right-hand facing sinus, and you'll note that all 3 of the coronaries arise from that single orifice. There is a very short common segment, and when you look at the aortic root from the inside, you can see that this was a very large common orifice with a very immediate bifurcation of the right and left coronary systems. And you can see I have it backlit in one just to demonstrate that very short common segment. Here we have a right coronary and a circumflex from sinus number 2, or the left-hand facing sinus, and the right coronary artery you'll eventually see as a short intramural course. The anterior interventricular artery arises from the right-hand facing sinus. So there are the right coronary and the circumflex with their separate origins from the aortic root, and there's the anterior interventricular artery. The right coronary, as I show with the black arrow, has a very short intramural course, and I'll show you that from the inside of the root in a moment. And there is the sinus node artery, which in this case is arising from the circumflex coronary artery. So this is the aortic root where you can nicely see the left orifice and the circumflex orifice, and the right orifice has to be documented by placing a probe in it because it's deep within the sinus and adjacent to one of those commissures. As it crosses that commissure, has a short intramural course. Epicardial course is also important, and as we all know, we can have the circumflex artery arising from the right coronary artery, and that'll pass behind the pulmonary trunk. And the anterior interventricular artery isn't shown here, but it had its own orifice from the right-hand facing sinus. This is a coronary artery where the circumflex has its own orifice, and the right and left, the right coronary artery and the anterior interventricular arise from the right-hand facing sinus anterior to the aorta and pulmonary trunk. And this is a specimen we'll see later today that has actually tricuspid atresia with transposition, and the anterior interventricular artery arises from the right coronary artery crossing in front of the aorta. This is a nice example, a long axis cut of both sides of a patient from UF that had an arterial switch procedure with a VSD repair and a neopulmonary artery patch. So you can see nicely the new pulmonary trunk that has been augmented with that patch. And here we see the neo aorta, and within the aortic root, very nicely, you can see those coronary artery buttons with a widely patent coronary orifice at the center. You can appreciate the sutures well away from the coronary orifice. So just a nice example to show what the repair looks like. As we've seen, there are many variations that can occur, and there are a lot of surgical considerations, especially with the arterial switch, which is most often done this day and age. Coronary artery anatomy is a definite risk factor, and extreme care is taken by the surgeon to avoid any tension or torsion, any angulation or kinking when relocating the coronary arteries. The increased risk of mortality when one or both of the major coronary arteries pass between the arterial trunks is noted, as well as patients having a higher mortality that have a single coronary artery or an intramural course. But despite all of these variations and all of these potential complications, surgeons adequately perform the arterial switch procedure today with remarkable success. Thanks for your attention, and if anyone has any questions or if there's time for that, I don't know how it's going to work.
At the panel. Next up, we'll welcome to the podium Dr. Lisa Hornberger. Dr. Hornberger is a world-renowned fetal cardiologist who currently practices at Stollery Children's Hospital in Edmonton, Canada. And she's going to be talking to us this morning about fetal imaging of detransposition of the great arteries.
I want to thank my colleagues for having invited me, and that includes Brad and Honey. It's been a long time. Jeff as well. It's great to see you, and Mark as well. So I'm really grateful to be here. And the one thing I will say, the one disclosure I do have is that I don't do coronaries very well by fetal every once in a while, but people think I'm crazy when I say that. So there we go. Anyway, so I'm going to talk about the evolution of prenatal detection, anatomical subtypes, and features in predicting acute neonatal presentation, which is probably one of the most important things that we do prenatally. And things have changed, certainly with what it was really wonderful to hear Matt's talk and the perspective of the patient. In fact, prior to 2010, we did terribly with prenatally detecting transposition of the great artery. So you can see internationally, these are all population studies that internationally showed very poor detection, including our own in Alberta. But in fact, with the implementation of new guidelines that have incorporated outlet screening, this has made a huge difference. For years, we've been great at screening the heart for four-chamber pathology and a lot of the big lesions that way. But in fact, outlet lesions, such as transposition, that many times have normal four chambers were missed. And now look at what has happened. So we had some Canadian guidelines with the radiologist incorporating outlet screening in 2010, and they were the ones doing a lot of our basic screening. And a lot of these moms are otherwise healthy women and otherwise uncomplicated pregnancies. And we saw a huge jump with just that being put in place, looking at outlets. And then with the American and European guidelines, which are ISHWAG and AIUM, you see that there has been another big jump. And today we're seeing more than 80% of them prenatally, which is remarkable. And has really allowed us to better fine-tune understanding, can we predict the restrictive foramen and the ductal constriction? And this is just showing you, of all the ones that did get detected prenatally over the many years that we have been following them, 92% were referred purely because of an outlet problem, not because of four-chamber pathology or because of a maternal health issue. It was very, very unusual, and certainly not because of genetic or suspected aneuploidy. So that just really hits home the importance of our screening of low-risk pregnancies and the importance of education in that area. So the anatomical subtypes are very much like what you see postnatally, and that includes the intact septum, which is the most common, ventricoseptal defects, about 8 to 10% represent the VSDs with pulmonary outflow obstruction, 3 to 5% the VSDs with subaortic stenosis and coarctation, and then there's certainly more complex pathology. I'll show you a fun case anyways, including straddling AV valves, hypoplastic ventricle, and crisscross AV connections. So just as an example, this just shows you how normal that four-chamber is. And if that's all you look at as an obstetrician or radiologist or sonographer, you're going to miss this diagnosis. It's very normal. Right ventricle is here, left ventricle here. AV valves look normal, and sweeping down, you'll see that the IVC is right there, and that's because they're situs solidus with a right-sided IVC. But as you sweep up, from that same view, you start to see the outlets don't really cross, and you see this bifurcating vessel coming off of the posterior left ventricle. That is the pulmonary artery, and out anterior and to the right, and this classic one is the aorta. So they don't cross. In fact, they're parallel. We're getting short axis at the same time or long axis at the same time. And that so-called three vessel view, which is also something we're working with our OB colleagues to really be using all the time, that Shiju discovered described many years ago, and it's lovely to have them in the audience. That's something that we know is a really important way as well. So just rotating a little bit to the long axis, you can see parallel great vessels coming off with, from that posterior left ventricle, a bifurcating PA, and the pulmonary and aortic valve look quite thin and moving well. The great vessels are symmetric and no obvious ventricular septal defect. And then with imaging, you can see that there's no obvious VSD and there's nice laminar flow through both outlets and arches. So we want to exclude outlet lesions as well as VSD, and then look to make sure that the aortic arch is fine. And you'll notice that the ductal arch is a little small, and that's actually classic for transposition prenatally. And then finally, we'll assess the foramen valve and duct, which I'm going to show you shortly. So just to note, this can be diagnosed at 13 weeks. This is mom sent for increased nuchal translucency, and you can clearly see that the great vessels don't cross. And that's because the pulmonary arteries are rising off the left ventricle and the aorta off the right. But rotating, you can really see that they're parallel. So we can make this diagnosis quite early. I am not going to call the foramen valve or the duct at this stage, mind you. And that's when the crown blunts about 1.5 inches. So just other lesions, you can see this is a 4-chamber sweeping up, small left ventricular outflow tract leading to the pulmonary artery and a much larger aorta in this baby with situs solidus. And this is going to be a posterior malalignment of infundibular septum that's impinging on the subpulmonary area, a small pulmonary valve, and then a much larger aorta and aortic outflow and a subaortic VSD. And by color, you can actually see flow from through the VSD into the aorta, so it's a subaortic VSD. This is the opposite side where there's anterior malalignment of outlet septum here, impinging on the subaortic area with transposed great vessels. You get a much smaller aorta. And of course, you're going to start thinking about a coarctation. And in this baby, there's a little bit of an override of that pulmonary valve, but in fact, it was mostly committed to the more committed to the LV and a much larger pulmonary artery. So subpulmonary VSD and anterior malalignment with subaorus. That three vessel view shows a much smaller aorta than the pulmonary artery. So that's something that we will use. And then, of course, you're anticipating this picture, which is the coarctation of this baby. And sometimes there'll be an interrupted aortic arch, as we all know, but there's coarctation in this context. And then finally, the fun one, just to kind of quick orient you, pulmonary veins coming to the left atrium. You'll see an AV valve here, and this is already giving you the clue. There's an AV valve here that gives rise to the left ventricle, which is inferior and a little bit more right-sided. And the tricuspid valve is going to come around and come off with the right ventricle wrapping around superior. So classic, or there is the pulmonary arteries are rising from that more right-sided inferior left ventricle here. And then you have to trust me on that. There's the tricuspid valve and the RV, and the aorta is anterior to the left. But in fact, this baby is detransposition physiology with intact ventricular septum. You don't recognize that. So you got a nice flat septum here that's very perpendicular, or is very parallel to the diaphragm, which it should never be. There's the mitral and tricuspid valve. In fact, this baby had an intact ventricular septum and an AV concordance, VA discordance. This was a transposition who actually needed an urgent balloon atrial septostomy. So we can make these kind of diagnoses, but you got to work on them. So clearly predicting the neonatal presentation is one of the most important things I think that we do. Obviously, you want to know all the pathology, and coronaries aside, we can't do. You want to make sure that as much as possible, you understand what the presentation is going to be like. And for the intact septum and those, especially with smaller ventricular septal defects, we want to make sure we understand whether or not this baby is going to present. And I'm going to show you some scary cases. So a severely restricted foramen occurs at anywhere from 20 to 40% of neonates, most of whom have a little bit of time that you can get there and take care of them, but it results in potentially consequent severe hypoxemia shortly after birth. Rarely it can be associated with ductal constriction. I will tell you that is a lethal condition if it's not recognized. Those babies go down really fast. I'm going to show you a case again that will put hair on your chest. Maybe you like that, maybe you don't, I don't know. So it contributes to as well the 6% preoperative mortality as the folks in Toronto discovered many years ago. So we always look at the atrial septum perpendicular to its plane. This is not a great example of that, but it was because I had better flow on this to really show good flow through quite a good size ASD, and this baby with transposition. I love to see this. I hate it when it's at all questionable. So from a sagittal view, you're seeing the IVC come up, and this is actually septum primum flapping beautifully away from the superior part of the atrial septum. This is left and right atrium. I love to see this as well. And then corresponding with that, this is our favorite view, is a really broad jet of flow going from the IVC, being split by that superior part of the atrial septum, and with a lot of it going to the left atrium. That makes me really happy. And then by still frame, you can see there's quite a large ASD. They're hard to see. And honestly, the time we're seeing them is in the third trimester and usually late in the third trimester. So you've got moms who are uncomfortable, we're uncomfortable, babies in a bad place, very tough. But we look for a thick atrial septum, a small foramen valve orifice. Sometimes some folks will use the foramen valve length, largest size to the total septal length of less than 0.5, but you can see there's some overlap, so it's not perfect. A fixed position of the atrial septum, a redundant atrial septum, and Norm Silverman and Poon et al. Had described the so-called hypermobile septum. That may or may not be, and it's also very tough to really put a finger on and quantitate. This is a good example of a baby with a very thick atrial septum and a small fossa ovalis, or ASD, that you can see tensely bowing of that septum primum, and by color, it's quite a small hole. You should never see something like that. That hole should be at least the size of the aortic valve. And in fact, this is how small this atrial septal defect was. The crazy thing is some of these babies, it's this tiny little flash. This baby was actually not acutely unwell. About an hour later was getting a septostomy, which is crazy because you just think, how are they actually even mixing at all? And then here in that same sagittal view, you can see a restrictive flap of that foramen valve, and by color, a very small jet coming up here and very high velocities. So it takes a long time to get this, but fortunately we now are seeing more and more of them, and we're getting it more and more right, as I'll show you. The duct itself is often quite small. You can see this is our study from many years ago, but the duct is small, and those with the smallest ducts, or the very, very small ducts or constricted ducts, are ones that get into trouble quite early. Ductal flow is also useful. So this is antegrade flow in systole, a little bit of flow in diastole. That is a normal flow profile, and we look for that. This is typical of transposition. I'll tell you, a lot of them have bidirectional flow, and it's because the PVR has to be low. There's no question, and I think it all goes with this, the pathophysiology of transposition in utero. So there's a bidirectional flow, tends to not necessarily identify the highest risk. This is the worry one. When you have constriction of the duct, sometimes it's closed, sometimes it's just really constricted. The LV is fine. It tolerates that just fine. It's getting ready to see the systemic pressure, which it would normally do, but obviously it's not. But you get this flow profile, and you have to worry. This baby came out with very, very low SATs, and we happen to have the team race on over to the maternal hospital and do a septostomy, which would have been a problem if that didn't happen and the baby had to be transported. I'll show you our data there. So in the normal circulation, you have more highly oxygenated blood that's going to go back to the left atrium, left ventricle, and feed the myocardium and the upper body. In transposition, the problem is you've got pink blood going into the left atrium, left ventricle, and more to the lungs. And just a few millimeters of mercury difference in PaO2 going to the lungs in fetal lambs, work that Rudolph has done and others have done, drops the PVR quite a bit. So you have increased flow through the lungs in the fetal transposition with increased pulmonary venous return that starts setting them up for a closure of that atrial septal defect or the foramen valve, and diverting flow away from the duct. So that's why we think that the duct is also small. So important things just to think about, but the pathophysiology is there, and it's very different than normal. And Mike Seed's done a lot of really wonderful stuff in MRI confirming those findings. So this is our problem, and it's not unusual. It's not a unique problem to us, but our mom's hospital, which is phenomenal, it's a coronary care center, as a phenomenal NICU, is here. And for those who don't understand kilometers, it's 3.7 miles away. I had to put that on. 3.7 miles away is our surgical hospital with all our cardiologists and surgeons and folks around to be helping, and our surgical NICU. That's a problem, but it doesn't look very far. Until you have geese crossing the one bridge that you're going to use, okay? That's a problem. That's a Canadian problem, although it might happen here too. Anyway, so no, I mean, you have traffic, whatever. The shortest time we can get the kids across is 46 minutes. So we thought about this because I have actually been someone in 30 years who have lost babies with transposition prenatally diagnosed, and if you don't get them there in time, you're in trouble. So we said, well, what's the wiggle room we need to get them there? And we said we wanted 2 hours. We want to be able to predict who's going to get in trouble within 2 hours. It's not a perfect science, but it was what we said we needed. So we just started saying, let's deliver those that we think are going to really get into trouble right away in our surgical OR, which is what we ended up having to do. We don't have a maternal unit in our children's hospital. So we take the high-risk fetal cardiac cases that we're really quite worried about. We get approval from moms first off if she's willing to do a section because we don't have a place for her to labor and don't have all the necessities. Also, if you have a really sick kid, you don't want to be waiting hours and having the team wait hours. It's not going to happen. Mom couldn't be have a high risk issue to be delivered in our Stollery Children's Hospital. We also wanted to make sure the baby was otherwise pretty healthy. We had to get OB-GYN approval, and then the case is vetted through our CV surgical conference. And we've done this now many times for other lesions. This is a very busy slide, but we've actually worked out a really smooth algorithm that as soon as we have said yes, we have a whole line of communication, multidisciplinary team. You see them, things seems like a huge amount, but we've had to do that for many really complex cases. Moms are actually admitted the night before to the mom's hospital. They're transferred over and admitted as a day surgical patient in our surgical unit, and they're there by 7. Our team meets by 7. The mom section starts at 7:30. They're out of the OR by 8:30, and that way the surgeons don't get unhappy with us. And it's worked great. Moms have to go over back because the whole obstetrical team goes back, and they go back within a few hours, and that's worked out really well. So we've resuscitated these babies. So what have we done? Since 2013, we've had 16 higher risk babies and 46 that were either less high risk or unclear risk. 11 had cardiac OR deliveries, and 5 others delivered before we were ready, and they went into labor, and we don't do laboring moms in our surgical unit. Of the 11, 8 required emergent BAS within 2 hours, and these are kids who are blue. 2 had quite small ASDs, including 1 of 2 millimeters, 1 of 4 that did not get into a terrible problem until 6 to 8 hours. And then we had 1 end up with an arterial switch at 36 hours because of being cyanotic and on inotropes. We had 5 early deliveries. All of them required balloon atrial septotomy. And just of note, 1 was arresting on arrival. It was the middle of the night. Everyone was ready. This kid crashed onto ECMO because we couldn't do the septotomy fast enough. He was too sick. And of the 46 others, 6 required an emergent BAS less than or equal to 2 hours, and 40 did not require a BAS in the first 24 hours. So it just gives us a sensitivity of about 70%, specificity of 93%, positive and negative predictive values of 80 and 87. This is just a scary case where the atrial septal defect wasn't even clear it existed. This is a very tethered atrial septum. And we said, well, probably small ASD, let's deliver on the surgical unit. You're seeing continuous flow that's very abnormal in the duct in keeping with a constricted duct. This kid's cord pH was 7.35, so delivered at 38 plus weeks. Within 10 minutes, this kid's pH was under 7. And this is our poor cath guys trying to get a catheter and wire across, which they could not. The atrial septum was actually intact. And so this kid was on pump and had an arterial switch within 45 minutes. But this baby would have died for sure. So the prenatal issues, difficult acoustic windows, findings don't evolve until late in gestation, which is when you have the worst windows, and we really need more sensitive predictors, but I don't think we're gonna get it 100%. And that's like coarctation. There are reasons that you just can't get it. Even with a very small ASD, there may be a honeymoon with decompensation hours later. And even with a reasonable sized ASD, you may have inadequate mixing with pH. So in summary, with improving obstetrical screening guidelines, certainly we've seen improvement of prenatal detection, thank God. The full spectrum of DTGA encountered postnatally can be diagnosed prenatally, except for coronary pathology, of course, or coronary anatomy. Meticulous attention to detail is certainly necessary to fully evaluate our patients to exclude associated pathology that may impact their neonatal presentation and their prognosis, and is absolutely critical for prenatal counseling, and certainly more work is needed to define and fine-tune our ability to predict the restrictive foramen. Thank you very much.
Lisa, thank you so much. As always, that was spectacular. Before we go forward, we got the final numbers for our virtual attendees. I want to welcome all of them who are listening and watching. We have more than 150 virtual attendees. We have almost 300 attendees for the conference, which is incredible. I want to thank all of you for being in person and obviously for our virtual audience. Our next speaker is Dr. Nicholas Suji. He's one of our assistant professors at Cleveland Clinic Children's, one of our cross-sectional imagers. Dr. Suji will be talking to us about anatomical and functional imaging of coronary arteries, including coronary stenoses. Nick.
Okay, thank you, Dr. Moreno, for that introduction, and thank you to the organizers for allowing me to present virtually. I really appreciate that. Hi, can you hear me?
Yeah, Nick, we can hear you.
Okay, thank you. So today I'll be talking about anatomic and functional imaging of the coronary arteries and coronary stenosis. I have no disclosures. So for an outline, I'll be going over the coronary artery transfer procedure, some atypical coronary anatomies, and then we'll talk about the mechanisms of coronary artery stenosis, and then anatomic and functional imaging of those. Now, this has been covered already, but the arterial switch procedure involves a closed coronary artery transfer, wherein the coronary arteries are switched over to the neo-aortic root. The usual anatomy is present in about 60% of cases. Here is a surgical picture showing the suture line within the coronary buttons. And I want to just talk about a few atypical arrangements that are important for the imager to think about. One is the single coronary artery, which is present in about 6% of cases. And the other is the intramural coronary artery, which is more rare at 2%, but is very important prognostically. Now, I won't go into too much detail as this will be covered in other talks, but there are certain surgical techniques that are important for the imager to know and think about. For the single coronary artery, one is the interposition graft, which is essentially a tube that connects the neo-aortic roots to the coronary artery orifice and is at risk of stenosing over time. And the other is in situ coronary reallocation, where the arterial wall is switched over to place the coronary ostium on the other side of the wall. And the same goes for intramural course, where unroofing is a mainstay of this, but then it can also involve a pericardial patch, commissural detachment and resuspension, or even using a sinus hood. Now, the mechanisms of coronary artery stenosis, there are several of them. Early in the postoperative course, kinking is the most common issue. As the patient grows, they're prone to stretching of the coronary arteries. And then a mid to late term issue is osteal stenosis. And common to these is intimal fibrosis, wherein the intima becomes hypertrophic and hyperplastic and narrows the lumen, as you can see by the black arrows and the fibrosis in blue. An intra-arterial course can also cause stenosis, and then there's a theoretical risk of atherosclerotic disease in this population. Now, what is the prevalence of this stenosis? A series of articles have been published on this, usually reported 5 to 8%, but has been reported as high as 12% in children and young adults. The risk of a coronary event or intervention by age 20 is around 4%. And past the initial postoperative period, the risk of coronary death in this young cohort is between 0.4 and 1%. Certainly a lot of cases have been reported of sudden death in this population. And one of the main risk factors, as was said previously, is intramural coronary artery. And in an earlier era, especially single coronary artery, or any kind of complicating factor of the operation. Now, when we place our patients in the center of this, and they have this risk of the procedure early in life and then a later risk of a coronary event, we think about risk factors, we think about symptoms. Sometimes symptoms of angina cannot be present because there's abnormal innervation of the myocardium. So imaging is really important for us to surveil these patients and make sure that we understand the risk for them. And the goal of imaging is to find out which patients might benefit from revascularization. So we'll start with talking about anatomic imaging. The historical gold standard for this is angiography. You can see a stenotic left main coronary artery here. However, in the current era, this is invasive. There's a need for anesthesia. And actually, conventional angiography has more radiation than CT. So this is a study from 2006 that first proved the concept that CT can be as useful as conventional angiography, where 49 patients underwent both, and 4 were found to have stenosis. and it found to have fully accurate screening of coronary artery stenosis. And we see on the figure to the left, osteal compression between two vessels, and the figure on the right shows the same of some compression of the vessel further downstream. And here's another CT example of stenosis of the left main coronary artery with a small luminal diameter of the proximal left main. And a few more examples of abnormal CT. So here's an example of proximal LAD stenosis caused by fibrocellular intimal thickening. And then there's also post-stenotic dilation of the vessel. And intra-arterial right, right between the neoace and the pulmonary artery. And then also acute angle of the LAD, which caused compression of the coronary ostium. And this is a potential area for further research. Here's a report from 2013 showing that acute angulation at the orifice is related to intra-arterial course, a high ellipticity index, and also a proximal kinking course. And all of these are a setup for development of intimal fibrosis. So this potentially could be an indication to follow these patients a little bit more closely with serial imaging. Now, cardiac MRI angiography can be as useful as CT for evaluating coronary arteries. The advantages are there's no ionizing radiation, there's no nephrotoxic contrast, and you can also obtain a simultaneous function and perfusion assessment using MR. Some of the disadvantages is that it's time-consuming, lower resolution, and lower signal to noise. However, in the past decade, these issues have been mitigated with image acceleration, motion correction, and advanced image reconstruction techniques, such that MRI is really catching up to CT. Now, here's an example of one of our patients. It's a healthy 27-year-old male who had usual coronary anatomy. You can see on the left side is his right coronary artery. You can see the origin and the proximal course very nicely in a 3D below it. And then on the other side, the left main, you can see the origin and then also the branching. And if we look at the adult literature, MRA has shown near equivalent prognostication to conventional angiography in acquired coronary disease. So I think the potential for getting very high resolution MR imaging of the coronaries is certainly there. It hasn't yet been looked at in a rigorous way in pediatrics, but I think it would be very good for this population. Next, we'll talk about functional imaging. And there's three main types that I'll touch on. First is stress echocardiography. Next is myocardial scintigraphy, and then stress MRI. So stress echo is essentially assessing regional wall motion abnormalities at rest and at exercise. Unfortunately, in this population, though it has high specificity, it has relatively poor sensitivity, in some reports as low as 36%. So next I'll touch on what perfusion imaging is. In general terms, the concept behind perfusion imaging is that a stress agent is given, and this causes coronary artery dilation of healthy tissue, and the tissue that's distal to a site of stenosis is already maximally dilated. So the coronary artery dilation of the unaffected tissue is greater than that of the affected tissue. So you have a difference in flow, which leads to what you're able to pick up on your imaging signal intensity. Now, with myocardial perfusion scintigraphy, or kind of a PET scan of the myocardium, the radio tracer that's injected into the patient, the uptake is proportional to the coronary flow. This is done at stress and at rest. And you can see here as an example, there's several arrows showing up areas of heterogeneity within the myocardium, showing a diseased portion of the LV tissue. Again, we're looking for heterogeneity in the myocardium. Now, this has been looked at in DTGA for quite some time. This is an early report from the 90s showing abnormal perfusion in up to a quarter of the segments, looking at 23 different children. These were all healthy patients with no ischemic changes on their EKG during stress. The thought here is that the perfusion defects might have been related to the insult of open heart surgery rather than the coronary artery lesion. So resulting from the surgery, there are some abnormalities that make it more difficult to use these tests or to interpret the results. So it's somewhat limited, though it still has its place in this population. Now we'll talk about myocardial perfusion imaging using cardiac MRI. Now, the basic concepts are the same. A stress agent is given, you give a bolus of contrast, and then perform rapid and dynamic imaging of the myocardium. So here's an example of this. You can see the contrast is first entering the right ventricle, and then it enters the left ventricle, and then perfuses the myocardium. And there's a subendocardial perfusion defect that's more prominent on the lateral wall. A few years ago, this method was looked at Texas Children's Hospital, and they were evaluating their experience using regadenoson as a stress agent, which again causes coronary artery dilation, which increases flow. And here's an example of their protocol. So the stress agent is given at the beginning of the scan, after the basic anatomic sequences, and stress perfusion is performed in the same way that we saw on the last slide. And then another dose is given at the end of the scan after the washout of the regadenoson, showing the rest perfusion. And then this is an example of a 2-month-old from that study. The stress perfusion shows a decreased signal at the septal, anterior, and lateral subendocardial walls. And this is consistent with abnormal perfusion. And at rest, there's still a small area of decreased signal intensity at the lateral wall and within the papillary muscles. And then this is confirmed with delayed hyperenhancement imaging, which shows a defect in the lateral wall and the papillary muscle. So here's a flow chart that was used to provide this diagnosis. So again, perfusion at stress and then perfusion at rest makes it a potentially fixed defect, and then delayed hyperenhancement is what provides the diagnosis of a fixed perfusion defect. In this study, they reported that 40% of their patients underwent cardiac catheterization, and there was excellent agreement between the finding of a fixed perfusion defect and an anatomic diagnosis of stenosis. So in summary, postoperative imaging is indicated to evaluate for coronary artery stenosis with a fair prevalence of 5 to 8%, with a higher risk of intramural coronary artery. And we can perform anatomic imaging by CT or MR, and functional imaging can be performed with stress MRI. Thank you.
All right, next up would be Dr. Jeff Jacobs, who will be presenting in behalf of Dr. Mark Bleiweiss. So Dr. Jeff Jacobs is a professor who just recently joined us at the University of Florida Congenital Heart Center, where he's one of our amazing CT surgeons, and he will be presenting the arterial switch operation and management of abnormal coronary arteries.
Thank you very much. I'm going to be presenting this talk for Mark, and Mark and I worked on this talk together. And again, Mark is very sorry that he cannot be here with us today. And what I'm going to do is discuss surgical management of patients with transposition of the great arteries and abnormal coronary arterial patterns. and I'll go through three portions in this talk. I'll review a little bit about the nomenclature, summarizing some information that was beautifully presented earlier by Diane Spicer. I'll talk about surgical techniques, and I'll talk about outcomes, starting with the nomenclature. And to do this, I'm going to use some cartoons that have been previously shown. These are cartoons from Professor Anderson, drawn by Gemma Sprice and described by Diane Spicer quite nicely. And Diane showed this picture earlier. This is a normal heart, and the surgeon has been deposited into the non-coronary sinus and is looking at the aortic valve. So surgeon standing in the non-coronary sinus of a normal aortic valve. On the right hand of that surgeon is the right coronary artery, which is by the Leiden convention called the sinus number 1, or the right hand sinus number 1. And at the left hand of that surgeon is the left hand sinus, or sinus number 2, which gives off the left coronary artery that bifurcates into the left anterior descending coronary artery and the circumflex coronary artery. So this is the overall picture and anatomic setup in a normal heart, with sinus 1 giving off the right coronary artery, sinus 2 giving off the LAD and the circ from the left main. In transposition, the surgeon is now deposited again into the non-coronary sinus of the aorta, but here the aorta is coming off of the morphologic right ventricle, so there's transposed great arteries, and the surgeon stands in the aorta here, and coming off the right-hand sinus, or sinus number 1, is now the normal left main bifurcating into an LAD and a circ. This is the most common coronary arterial pattern in patients with transposition of the great arteries, with the right-hand sinus, or sinus number 1, giving off the LAD and the circ, and the left-hand sinus, or sinus number 2, giving off the right coronary artery. This picture, therefore, shows the most common variation of coronary arterial patterns in transposition of the great arteries. One other thing I would point out before we move on is that sinus number 1, which is called the right-hand sinus, is called by others the left-sided facing sinus, because it's the facing sinus that is on the left side of the body. And sinus number 2, which is the left-handed sinus, because it's on the left hand of the surgeon in the non-coronary sinus, is also called by some people the right-sided facing sinus. So there's a lot of names for these different sinuses, and that's why keeping it as Diane described it, sinus number 1 and sinus number 2 is perhaps the easiest way. This is some pictures of the most common coronary arterial patterns published in a paper by Jim Jaggers in the Annals of Thoracic Surgery. And I'm going to go through each one of these just to talk about what are the common and rare coronary arterial patterns in transposition of the great arteries. So this is the usual pattern. It's present in the majority of patients with transposition of the great arteries. And this is the one we looked at before in the cartoons, where sinus number 1 gives off the LAD and the circ, sinus number 2 gives off the right. Most common variation in transposition of the great arteries. Now here's the most common variant of that. If one doesn't have the usual pattern, the next most common variant is the circumflex coming off of the right. So here sinus number 1 gives off the LAD, and sinus number 2 gives off the circumflex in the right, the most common variant. Another variant, which has been described and termed posterior looping, my friend Francois Lecorgaillé likes to call this the posterior looping pattern, is where all three coronary arteries come off of sinus number 2, and the LAD and the circumflex vessels coming off of a left main loop behind the arterial trunk. There's also an anterior looping where LAD and circ and right come off of sinus number 1, and the circumflex and some of the LAD loop anteriorly. And then there's a double looping pattern, which is inverted coronary arteries. Here, the right and the left are switched from where they normally occur in transposition. So sinus number 1 gives off the right coronary artery, sinus number 2 gives off the LAD and the circ, and both of them loop around the great vessels. Then another pattern that exists is the inverted circ and right. And here what happens is the LAD and the right coronary artery are coming off of sinus number 1, and sinus number 2 gives off the circumflex. So here the circumflex and the right are inverted from their usual position in transposition. Then here's some of the more challenging ones. There's a pattern called posterior looping with an intramural coronary artery. This is the same posterior looping pattern as described before, but this pattern is commonly associated with an intramural coronary artery, where part of the lumen of the coronary artery is contained within the wall of the great artery. And finally, this is another picture where we see an intramural left anterior descending coronary artery. And I'll show some pictures of how to manage these intramural coronary arteries in a minute, but these variations are amongst the most challenging. Again, we started with this pattern, which is the usual pattern that occurs in most patients with transposition. And what I'd like to do now is just show some simple intraoperative photos of how the usual pattern is managed in an arterial switch operation. So then we can go from what we do with the usual pattern to what we do with some of the rarer variations. Before I do that, I want to draw attention to one final series of pictures. This is in an article by Sarah Pasquale back from 2002. But this article does a very nice job of looking at the different ways one can imagine looking at the great arteries and the coronary arterial patterns. So if one looks at where it says usual, which is the pattern that I had just talked about as the most common variation, the top picture under usual is the picture that I've been showing, which is from a diagnostic projection. But if we look at the picture immediately below it, that's what it looks like in the operating room. So the picture immediately below it shows what one would see if a camera was attached to the overhead light immediately above the heart. And these are showing the same exact pattern, but from a different perspective, one from the imaging perspective and one from the intraoperative perspective. And I think that's going to be useful as we look at some of the surgical pictures. And this, again, zooms in on what I just showed. And we can see how each one of these variations of coronary arterial patterns can be drawn either from an imaging point of view in the diagnostic projection or from an intraoperative point of view from the frontal view, looking at what the heart would look like from a camera hanging above the operating table. Now let's look at doing an arterial switch with this usual coronary artery pattern. So we're going to look at some surgical techniques with this usual pattern. This is a photo from the camera above the OR table that has a picture of the heart. And here we can see that is the morphologic right ventricle on the anterior aspect of the heart. That's the aorta coming off of the morphologic right ventricle. So here we can see this patient has transposition of the great arteries. If we look at that same picture a little more, there's the aorta, there's the pulmonary artery. We've now, in this heart, we've pulled the aorta to the side a little bit so we can see the posterior pulmonary artery coming off the left ventricle. Here's a picture where we now have a pair of forceps on the right ventricular outflow tract going into the aorta. We can see that's the right atrium that yellow arrow is pointing to, and we can actually see the superior vena cava going into the right atrium. There's the right ventricle. There's the aorta coming off the right ventricle. So that's transposition. And just for orientation purposes, that's the lung that's the left lung in the open pleural space. This picture is set up so that the patient's head's at the left of the picture, feet are at the right, and the surgeon is standing just below the right atrium. Here's that same picture again, same heart again, but now we can actually see the right coronary artery that's coming off of sinus number 2. So in this picture, we see the aorta coming off of the right ventricle, and we can start to make out the right coronary artery. Now, this is later on in the arterial switch operation. We've gone on bypass. We've given cardioplegia to stop the heart from beating, and we've transected the native aorta and excised the coronary buttons. This yellow arrow is pointing to the excised left main, and that's going to later bifurcate into the LAD and the circumflex vessel. Below that, we can also see the right coronary artery, and we can see those yellow loops that are looped around the branch pulmonary arteries. So the second arrow on the bottom there is now pointing to the right coronary artery. Those are the coronary arterial buttons. That third arrow I just put there shows the place where the left coronary button was excised from the native aorta. And that arrow points where the right coronary artery was excised from the native aorta. And this is the setup that one has when one is about prepared to begin coronary implantation. And the next step is going to be to transect the pulmonary artery below and create a location for coronary implantation. So now the pulmonary artery has been transected, and we can see a needle that is suturing a coronary button of the right coronary artery into the neo-aorta. That arrow points to the right coronary artery being sutured into place. And if we zoom in a little bit closer, we can see the sutures being placed. There's an arrow pointing to the right coronary artery being sewn in. And that arrow shows the left coronary artery, which has already been sewn in. These two coronary arteries have been sewn into the neo-aorta as coronary buttons placed into a slit incision or a punch hole in the neo-aorta. And I'm going to show a lot of different ways. The technique used at University of Florida now is that Mark most commonly utilizes is a trapdoor mechanism, but this picture happens to show the implantation of the coronary arteries as coronary buttons into a punch hole into the neo-aorta. So here we can see again the sutures being placed to suture the right coronary artery into place. And immediately to the right of that, we can see the native aorta, which is going to become the pulmonary valve. And you can see where one has removed those coronary buttons. So that's the right coronary artery there being sewn in. Now the coronary arteries have been sewn into place. The pulmonary artery has been translocated anterior to the aorta with the Lecomte maneuver. And the surgeon here is now suturing the aorta back together, creating the neo-aorta. So that's the pulmonary artery that's been translocated anterior to the neo-aorta with the Lecomte maneuver. And that's the neo-aorta being reconstructed with an end-to-end anastomosis. After that is done, the next step is to reconstruct the pulmonary valve and neopulmonary artery. So the first step here is a pantaloon patch is being used to reconstruct the neopulmonary valve to provide tissue in the place where the coronary buttons were excised. So this is an autologous pericardial pantaloon patch being sutured into the neopulmonary valve in the locations where the coronary artery buttons were removed. And that arrow points to the pericardial patch. That arrow points to the neopulmonary valve, the native aortic valve, which is coming off of the right ventricle. And then the next step is to sew the pulmonary artery back to the pulmonary artery to create the neopulmonary artery. So the native aortic valve is now sewn to the pulmonary arteries at the area of the Lecomte maneuver to complete the arterial switch. And that's that last suture line coming together there. So the photographs that I just showed demonstrated implantation of the coronary arteries as coronary buttons as shown here with diagonally oriented slit ellipses, slit incisions or elliptical incisions. This is another way that can be done with trapdoor incisions instead of utilizing the diagonally oriented slit incisions. This is the technique most commonly utilized at the University of Florida. And when this is done, the right coronary artery is actually typically placed more distally on the aorta with part of it going across the suture line. Now, in the setting of intramural coronary arteries, one cannot simply cut out the coronary buttons or we would have transection of the coronary artery, which would be an intraoperative disaster. So this is one technique to deal with intramural coronary arteries where the coronary artery is unroofed as one would do for an anomalous aortic origin of the coronary artery. And after unroofing the coronary artery, one can then have a button to use for implantation. So the surgeon places a probe or one arm of the scissors into the intramural portion, unroofs the intramural portion, and creates the opportunity to create two separate buttons. Another technique that avoids the need to unroof an intramural coronary is to excise the coronaries together and bring them back together to the reconstructed area with the pericardial patch. So here we have the two coronaries excised as one common button, and they're then brought to the neo-aorta with the pericardial patch. This is another variation on that theme. This is the modified Albert procedure, where one doesn't even need to excise the coronary buttons and simply uses a strategy of leaving the coronary arteries in situ, covering them with bovine pericardium, and perfusing the coronaries by creating an aortopulmonary window. So this is just a quick summary of the various techniques that can be utilized to deal with abnormal coronary arteries. One could talk about each of these techniques for 30 minutes. I'll wrap this up by just spending about 1 or 2 minutes on the various outcomes. I'm going to talk about two papers. This is a paper that was written by Dr. James Kirkland, the senior of the two Kirklands, back in 1992 from the Congenital Heart Surgeon Society study. They looked at outcomes of patients undergoing the arterial switch operation with abnormal and normal coronary arteries. And they found, underlined in blue here, is that the origin of the left main coronary artery or the left anterior descending coronary artery or the circumflex coronary artery from the right posterior sinus was a risk factor that was even stronger when an intramural coronary course was present. So here they identified certain patterns that were high risk, especially intramural. This is back in 1992. And their conclusion was that certain coronary artery patterns and certain institutions lessen the goodness of the outcome. That's a direct quote from the conclusion of this kind of landmark paper that showed that there's certain high-risk coronary arterial patterns. Finally, I'd like to show data from a decade later from a paper by Sarah Pasquale. I showed some pictures from that before. This study looked at 9 independent series looking at death after the switch operation to look at what was the risk factors of various coronary arterial patterns. And they found out that single coronary patterns with looping around the great vessels were associated with significant increase in mortality with an odds ratio of 2.9. Meanwhile, the common variations like the right from the circ did not have increased risk. So variations without looping, such as a circumflex from the right, were not associated with increased risk. Finally, intramural coronary arteries had the greatest risk of all with an odds ratio of 6.5. And they kind of concluded that patients with any variant of the coronary arterial pattern beyond the usual had almost twice the mortality seen in those with the usual pattern. The highest risk of all were single ostium patterns, intramural coronary arteries, and patterns with looping. So Pasquale in this paper concluded that over the past 2 decades, patients with common coronary variants have undergone the switch without added mortality compared to those with the usual pattern. But the rarer forms like intramural and single coronary arteries had significant added mortality that has persisted over time. We now have techniques to construct these rarer variants with less risk, but they're still amongst the most common arterial switch operations that are performed. I tried to cover a little about nomenclature techniques and outcomes. Again, Mark Bleiweiss is sorry that he can't give this talk, but I'm happy to do my best to stand in. Thanks.
Jeff, thank you to you and Mark. Great presentation. Our last speaker in this session is Dr. David Cooper from Cincinnati Children's Hospital Medical Center. He's a professor there. As you heard, he's the director of the Heart Institute there. He's going to talk to us about pearls for critical care after the arterial switch operation. I think Dave and I chatted last night, and we said that literally he could sum up his talk in 1 sentence.
I think I'm going to. If I have my slides up, please. All right. Well, thanks to everybody on the organizing committee for having me come and join you today to talk about some critical care after the arterial switch operation. So here we go. So I have no financial conflicts of interest. Of course, I'd be willing to acquire some. My children tell me I need to do more hashtagging to be cool. So hashtag money for nothing. This could be a very well abbreviated talk. Dr. Hornberger shared some amazing fetal advances in my goal to be an overpaid babysitter. It has been amazing what fetal cardiology has done for us, and their ability to make preoperative diagnoses make my job so much easier. But the slides shared by Diane are a sobering reminder that when we have to demonstrate anatomical pathology using pathologic slides, that these patients are still at risk for bad things happening to them. It really wouldn't be a very good critical care talk if we're not reminded that in the principle of garbage in equals garbage out, which can lead to very profoundly sad cases, that I'm going to briefly talk about preoperative evaluation because it really sets the stage for a good postoperative outcome. So as in our center, as I'm sure in yours, most patients are extubated and eating. They're not very critically ill, but not all of them. So remember that we should assess these patients preoperatively for cyanosis, and that is really truly the only need for a balloon atrial septotomy because those are not without risk. While we accomplish that task mostly without injury, there are a few patients that have untoward outcomes. We can see persistent pulmonary hypertension most marked by reverse differential cyanosis. and that may be a risk factor for postoperative pulmonary hypertension, which is a known complication for the operation. We must have a clear understanding of the coronary arteries as shared by the prior speakers, perhaps the most hazardous part of the operation, and timing of surgery matters, whether it should be done within the first week of life, whether there's some preoperative risk factors that say we should delay the operation, but when we ask the surgeon to take the patient to the operating room does matter. So in preparing this talk, what I'm going to share from you here, this is table 27 from the most recent harvest of the STS database, the largest collection of operations in the United States. And it was very, very interesting to me to review the data because, again, in my center, like yours, all these patients are supposed to live and don't have problems. But the database would remind us that that is not particularly true. I'm really going to just highlight three versions of transposition. So transposition intact ventricular septum and those patients that underwent arterial switch operation. You can see that comprises most of the patients in the database, having about 67% of the patients. There's transposition VSD who undergo switch and VSD repair. That's another quarter of the patients. And then transposition VSD who undergo switch and aortic arch repair and VSD closure, about 6% of the patients. Now, there are other varieties, but this clearly encompasses most of the patients that we will care for in the intensive care unit. You can see that most of these patients undergo operation in a median of 6 or 7 days. This is supported by, most recently, the paper out of the Columbia group looking at timing of arterial switch operation and outcome. So again, important in so much as timing of that operation matters for those that should go early versus late. There are certainly preoperative risk factors. I was very surprised to find that half the patients receive some form of mechanical ventilation preoperatively, which again is not a common finding in our unit, and probably self-selects a fairly sick group of patients and or those that were inadvertently intubated by our neonatal colleagues. They can have bleeding disorders. Preoperative neurologic deficits are quite small. That may be a function of who gets imaged and who doesn't. And infection is not an inconsequential risk factor, perhaps speaking to the timing with which we do the operations. There's a very small percentage of patients, so only 10% of patients have some type of chromosomal or syndromic malformation. And then again, looking now at operative mortality is not zero. Those that have an intact ventricular septum have the lowest mortality, less than 2%. But if you have a VSD or you require your arch to be reconstructed, you're looking at 6 and 8% mortality. So 6 out of 100 and 8 out of 100 patients die, which again is not a very common thing that we talk about after this operation. And the length of stay for these patients, while it can be short as a week, not uncommonly they're in the hospital for postoperatively for 2 or 3 weeks. So again, not consistently low. So in the CICU, so how do you talk about critical care for a patient that has an arterial switch operation? Well, it reminds me of an adage that I might have heard from Gil the first time, I don't know, but I can't make a bad operation good. I wish I could, but I can make a good operation bad. Very well so. So it really sums up intensive care in DFIU, don't it up. So these are postoperative problems that you can see. They're fairly banal, bleeding, low cardiac output syndrome, pulmonary hypertension, of course, residual lesions, although our surgeons tell us they never have those, residual VSDs, arch obstruction, outflow tract obstruction, again, very uncommon, but not zero. Arrhythmias, such as atrial tachycardia and junctional tachycardia, again, not common, but not zero. You can have later effects when you try to go to extubate the patient, like stridor from vocal cord injury or respiratory insufficiency from a paralyzed diaphragm. Again, very rare, but important to detect and intervene upon. And then the last two are probably the most scary, which is LV dysfunction, which you can see without coronary artery ischemia. And then the last one being very important, coronary artery issues or ischemia. And again, while very uncommon, very important to detect early and intervene upon early in order to salvage those patients. So how common are these things? So this looks at the complications reported again from the same table, table 27 in the most recent harvest. So this is from January 2023 from the STS database. You can look here at the 5 most common complications. So unplanned cardiac reoperation. Now this is not for bleeding, this is for residual lesions. And again, not uncommon. 6% in those that undergo a switch with intact ventricular septum. And then double digits, 11 and 16% respectively if you have a VSD or if you have an arch repair as part of the operation. So again, not unimportant to consider. Cardiac arrest does happen in this patient population, almost 3% and 6% depending on lesions. These patients can receive mechanical circulatory support in the postoperative period, double digits in those that have an arch repair as part of their procedure. I was really surprised about this because I haven't seen an open sternum in a transposition patient almost very, very infrequently. But in the database, a third of patients will have an open sternum, planned open sternum, not unplanned, planned open sternum after the operation, which I think I'd have to say I've not seen in my career in multiple institutions that the sternum was left open in a planned fashion. But over half the patients in the database have it if they have an arterial switch operation that includes an arch repair and a VSD closure. So fairly sobering and surprising. And then again, bleeding, not common in mine, I'm sure in your institution, but upwards of 10% patients have a reoperation for bleeding if they have an arch repair as part of their arterial switch operation. So not zero and does need to be managed. So when we think about these patients, again, we need to address the gap between knowledge and execution, and that relates to having experience and judgment. And we all know that good judgment is the result of experience, and experience is the result of bad judgment. So we want to treat these complications that we see before what the end result of most of these are, which is cardiac arrest. This was a paper put together led by Jeffrey Alton from the PC4 database looking at cardiac arrest in pediatric cardiac ICUs that was published in 2017. It's sobering that cardiac ICU patients have the highest risk for cardiac arrest of all hospitalized pediatric patients. 3% of pediatric patients with cardiac disease will have cardiac arrest. And the sobering fact is that 50% of patients who suffer cardiac arrest will die. So it is a complication that we must avoid. This complication can result from the complications I discussed earlier. And you think, again, like I said, if you look at arterial switch operations, it is not uncommon that they have a cardiac arrest. And when they have a cardiac arrest, their risk of survival goes down markedly from 97% to 75%, and from 96% to 67% in those that have an arterial switch with a VSD. So while we say it's an arterial switch operation and they all do fine, we know that's not true. We have to be ever vigilant and function as a team when these patients deviate from normal convalescence. And again, the most challenging being that with coronary artery anomalies or residual lesions. So I would say any patient that comes out requires mechanical circulatory support to leave the operation, needs an immediate cardiac catheterization. Don't delay. Again, you can sometimes see LV dysfunction, global LV dysfunction. We've had a couple of those cases related to the size of the hole and timing of the operation. But the coronaries are the first and foremost that need to be addressed. And with that, I'll conclude. I'll invite everybody here and online to join us at the 8th World Congress of Pediatric Cardiology and Cardiac Surgery in Washington, D.C. This summer. And thank you very much.
Dave, that was terrific. Thank you so much. Very sobering data. I think you and I have worked with excellent surgeons throughout our career. I'd like to call Lisa and Diane up to the dais now so we can have our discussion period. For those of you that are listening virtually, please feel free to put questions in the Q&A box, and our moderators will monitor that and ask questions as appropriate. While we're getting our colleagues up here, Jeff, thanks for coming up. I'll ask the first question, and it's for Nick Suji. Nick, can you hear us? So Nick, I think you gave a great presentation of the many ways in which we can assess coronaries for perfusion defects and potential myocardial ischemia. Can you tell us what is the gold standard today? And based on what you showed us, what should the gold standard be tomorrow?
Sure. So if you look at the current ACHD guidelines, and I think those are applicable to our probably our older children, adolescents, and young adults, it does recommend doing an anatomic assessment of the coronary at some point following the operation. Earlier literature recommended doing it at multiple points, but right now it's at least one point. And doing some kind of functional imaging every 3 to 5 years. And I think those higher risk anatomies probably warrant more close follow-up. Now, with our current MRI protocols, I think we can get a lot of that information and monitor serially, every 3 years to look at both the coronary artery anatomy as well as perfusion and function. I think in the future, I would like to see more high-resolution imaging of the coronaries, and also if we're able to gather larger patient populations of especially those kind of complex anatomies, it might help us to tease out what sorts of things are imaging biomarkers that may warrant closer follow-up or even intervention for any sort of stenosis.
And Nick, I think your last point is really, really important because while the incidence of sudden death in our arterial switch operation population in the second and third decade is very low, it still happens. And if there's a way that we could find an MRI functional biomarker that would predict who would be more likely than other patients to have a sudden death event or a ventricular arrhythmia, that'd be really helpful. Thank you, Nick. Dr. Najim.
Great. Incredible talks. Thanks to all the faculty. So we can't have an arterial switch mortality. That's what everybody else. All the programs are gauged by their outcome for arterial switches. That's how you do well or not do so well. And we've done a lot to mitigate this, I have to say, from fetal imaging to early intervention to better surgical technique, better diagnosis, better surgical technique, and ICU care. We still have them, as David has shown. Now, are we going to ever to get it to zero? I'm not sure we can. There are still some, despite all that, we're going to still see some of those patients that will not do well, not the fault of any of the series of the program. I have personally done more than 350 switches, and I still put in an LA line in every switch that I do. And I know a lot of surgeons do not do that and think that, I've done enough of them, I don't need an LA line. And it's not for me, it's actually for the ICU care. So my question to the surgeons in the room and to the intensivist, does this, you think, Mick, because this is the earliest sign of ventricular or coronary problem, as David has shown, would be an elevated LA pressure. So my question is, for the intensivist, do you actually want that? And for the surgeons, do you do that or not? Show of hand on the surgeons. Do you like to do the LA line? Do I want to lie?
Okay, Christine. Absolutely. Yes. Surgeons first, as always.
Of course. Dave, what do you think?
So I have not had an LA line in arterial switch in 15 years, 20 years almost. Early on, so in the late 90s, early 2000s, during fellowship, and we would see them relatively routinely. And then the surgeons I work with just stopped using them. And I have to honestly say it's not made much difference in our care. As I said earlier, and it sounds like people will do it routinely, we routinely, and the surgeons I've worked with routinely close the sternum. So only in a handful of cases have I seen them come out with an open sternum, and it was never planned. It's always unplanned, bleeding or some issue. I think if you, so I haven't seen them, I don't use them, I don't think we need them. I think the physiology that Christine describes is 100% accurate. It's particularly if the LV is a little on the smaller side, a little bit of volume. I have to say that the surgeons I've been blessed to work with, get it right, and coronary stretching isn't so much of a thing anymore. It was often talked about, but rarely seen. I do think that the timeliness of making the diagnosis of coronary ischemia is important. It's not always evident in the operating room, and it can become a problem that that often develops over time, because if it's in the operating room, the surgeon addresses it right there and then. I think the key is ST segment monitoring and changes in ST segments or unplanned ventricular dysfunction. And most of the time, at least when I've seen it, is either because of something left behind in the sternum, like gel foam or something else that swells with time. And when it swells enough, it amazingly compresses the coronary artery. So, and we also, extubate them either in the operating room or shortly, within the first day of the operation.
I have to challenge you, David, on that. So, because obviously the answer is easy to say this because we never had. So that means if you have to say that there's no need for an LA line, you've had 0 cardiac arrest post-op, you've had 0 ECMO, and you had 0 mortality. And if you didn't have in these last 15 years any of those, I think the LA line makes a difference with early. The ST changes, you're not going to see it in a subtle coronary ischemia. You're going to see only ST changes when you have massive ischemia of the left ventricle, left main. You could see it on the right. You don't see it on the left sometimes. The ST changes is late, and by the time you see it, the LA line is the first thing to tell you in the operating room or in the ICU whether your fluid management is good or you have a little bit of a band, usually standard. We don't leave any firm material or gel foam or anything to swell after surgery. We leave what could be a band or something that is that. In addition to the TEE, I think is important in the operating room. Jeff.
Well, there's clearly a lot of passion in some of this discussion here. So I got to weigh in on this. I can't just sit here and listen. And I made some notes. First of all, Coop says they never leave the chest open. Gulasarian texted me. She selectively leaves the chest open, especially if it's a TGA VSD arch, but she usually closes them if it's a switch or a switch VSD only. In Gainesville, essentially all the switches come out with an open chest for the first 24 hours, and then they're closed on day 1 or day 2. There's a lot of ways to do things, and each center needs to choose what they think is best. Coop never uses LA lines. Ani always uses LA lines. In Gainesville, we selectively use LA lines. Coop never closes the chest.
I never close the chest.
And he never should. Coop never leaves the chest open. In Cincinnati, they never leave the chest open. We routinely leave the chest open. You never use an LA line. You always use an LA line. The pictures I showed coronary buttons being put in through slit incisions or punch holes, which is that was one of my cases that I showed with all those intraoperative photos. Mark uses trapdoors. There's lots of ways to do things. The key is doing something that works in one's own center and is reproducible. And I think it's not ever right to say that one should never leave the chest open. One should say, in our center, we don't leave the chest open, but there's other ways to do it. And I think there's a lot of ways to do it that work.
And Jeff, just to add to your comments, worked at 4 institutions between my training and my attendingship. Even within single centers, different surgeons do it very differently. So it's not that centers do it exclusively a certain way, it varies within centers. I want to pivot now to a question for Dr. Hornberger from one of our virtual audience members. Dr. Hornberger, this individual really enjoyed your talk, and the question is, have you used maternal hyperoxygenation to help with risk prediction in antenatal TGA?
Yeah, it's a good question. Firstly, we've done studies in normal fetuses, and there's extremely variable response. And to some extent, it depends, and it's all in the 3rd trimester. And I know that there had been some previous work out of Norway that suggested it was a really consistent thing. It is not. So a normal fetus actually sometimes responds and sometimes doesn't. And the farther you are as close to term as possible, the more likely. Now you take a transposition fetus, and honestly, there's a lot of variability. We have a prospective, and this probably person already knows, we have a prospective multi-center study currently in fetal transposition with the Fetal Heart Society that will hopefully have some more data. I find it's very variable, but maybe with larger numbers, we'll know how to better understand, whether there's really a role for maternal hyperoxygenation. It is a tough one, though, I have to tell you. It's taken years to figure it out.
One other question, Dr. Hornberger. That's a great talk. What's sobering is how much do you still see a lot of undiagnosed transposition in this era? And the follow-up question is, with your current distance from the maternal site and then your Stollery, the Children's Center, do they still die? And have there been improvements in transport and or OB detection to mitigate this?
Right. I mean, so the detection rates are very variable depending on where you go internationally, right? We looked at our population in Alberta to specifically look, and others have shown somewhat similar detection rates. So we're talking the vast majority, so over 80% are now detected prenatally, and that includes the simple ones, which are the ones that we most are concerned about with respect to falling apart. For us, so when I first went to the Stollery, firstly, a lot of people say, they don't die that quickly. And until you have it happen, you don't believe it. And the number of colleagues that I've heard say, we'll get them there. They don't die that quickly. I'm like, all it takes is one, and you say, oh yeah, they die. And as soon as I had this one in the OR, who basically they couldn't get across, that was exactly where they were like, okay, you're right. Do whatever you want. But so that's the issue. So we have really made a concerted effort to the higher risk ones where we can see them deliver in our cardiac OR. It's not perfect. It would be great to have a whole maternal unit in our Stollery cardiac program. We don't have one. So for the moment, that's what we have. But honestly, out of the 5 that mom went into spontaneous labor early, and we've now started even figuring out when we need to deliver them, the one we couldn't get across in time, the kitty was literally arresting en route, and just tells you. But we initially try to do them over at the mom's site, which would be great, except we don't have the surgeons and the others around if you get into trouble like we did with this one. So our team has decided they would way prefer having the baby in our unit. Guys who are doing the balloon atrial septostomies love us because it's at a known time. It's not in the middle of the night. Most of them otherwise are at 2 a.m. and half the team's not there. So it is really helpful because we have a very concerted, controlled. We don't just automatically do septostomies. As you can see, I had one with a 2.5 millimeter ASD. We didn't actually do anything because our stats were good initially. So we waited a few hours. To be honest, as a cardiologist, I think it makes sense just to do it because that kid's going to get blue. But just to prove the point that we shouldn't be just doing them. Let's just see what they do. And we eventually did her septostomy. So that's kind of our approach right now. It's not perfect. I mean, that means that the moms are having cesarean sections, which is not ideal. That's about 80% of our moms, it's a primary section, which is not perfect. But we about 30 to 40% of them would otherwise get them at the maternal unit. So it's higher, and that's a risk to mom. But the families are wanting that as well, knowing the risk of having to transport a sick baby.
We developed a maternal delivery unit at our hospital for that exact purpose, because prior to that, you'd have to bring them and have to do a C-section if you wanted to prevent babies like that from dying. And all you have to do is see it once, and it is impressive. And I'll tell you, we don't like surprises. So it's been very nice. So now the moms can deliver in the hospital. They can have a regular, labor and a vaginal delivery, and they can be taken right from there to the cath lab.
So we would not have saved that baby in that context, I don't think. So I think the problem is if that mom goes into labor and delivers at 2 a.m. and the OBs can't plan it and perfectly time it. I can tell you we have tried, and I've actually sat in cath labs for hours waiting for a baby to be delivered in a critical PS with severe TR who was hydropic, So that's the only downside to that, and it's sort of still, So that's why we've sort of said, okay, we're going to take this, and the OBs aren't 100% happy, and we're not 100% happy. If there was a better way to time a regular delivery, we would do it. And I don't know. I've been involved for 30 years. I haven't yet seen an OB actually get it right.
We'll do C-sections for those babies, but even the others that are high risk, now they'll deliver at the hospital.
Yeah, that's great. That's great. If you can, I mean, it's important for mom's reproductive health as well, and it's a good way to be delivered generally for the baby. So there are good things on both sides, but just we haven't been able to do that. So.
It's interesting. I've worked in 3 systems with 3 different models of this in my career. So when I was at Cincinnati before Dr. Cooper came and joined us there, we didn't have the SDU at Cincinnati, and there was a baby that literally came from one of our local hospitals, 15 minutes away, died in the cath lab. Yeah. It was one of the more traumatic events I've had in my career as a cardiac intensivist. We're all there, could not get the balloon across. Surgeons came down, couldn't save the baby. Now it's an SDU at Cincinnati Children's. When I went to Chicago with Prentice Women's Hospital, literally being built right next to the Children's Hospital, There was literally a skyway that joined the delivery rooms right into our cardiac ICU at Lurie Children's. And, during my 7 years there, at least 12 times a year, we'd have babies literally that we would say, when this baby's born, don't put in UAUV, just literally roll them across the bridge to the cardiac ICU where the entire team is waiting to do the balloon and the surgeons are available. That worked really, really well. Now Cleveland Clinic, because we have our own dedicated SDU, which is literally across the hall from the cath lab, which is amazing, we don't worry about that. And obviously with our surgeons right there, and we have a hybrid cath lab, we can have a full OR team, ECMO team right there, literally across from the delivery room, which is really, really helpful. I think hearing this conversation, I think at whatever center you're at, you have to figure out what's going to place the baby and the mother at the lowest risk and try to get the appropriate resource to that baby. I want to pivot for a second and then talk to the surgeons about some of the sobering data that Jeff brought up in terms of some of the longer-term outcomes relative to the coronary abnormalities. So 25 years ago, when some of us on the dais were training, surgeons were allowed to have their learning curve. And they would do every switch that came in, and they would learn how to do some of these less common opportunities in terms of taking care of these more unusual coronary patterns. As I got older, working with different surgeons, I was told ultimately, there's no coronary pattern I can't switch. Now, that didn't necessarily mean that there was a perfect outcome, but they would always say that there's no coronary pattern I can't switch. But in the current era, with US News and STS and everything being looked at under a microscope, and I'll tell you, I've talked to a lot of my colleagues who are younger surgeons. They're not getting the cases. They're not being allowed to have a learning curve. They're not being able to take on these tougher coronary cases. And when all of you, the senior surgeons in the room, retire, and that's going to happen, who's going to step behind you, and how are we going to get that ability to keep that mortality rate really low from these more uncommon coronary setups? Silence.
No, I think it's all about mentorship. Senior surgeons who do this operation and do it well need to mentor the next generation. A young surgeon should never be all alone trying to do an arterial switch without a gray-haired or no-haired surgeon standing opposite him who has the experience of doing the operation. And in a controlled setting with the right mentorship, one can go through the learning curve with the minimization of morbidity.
I think you talk about surgical, it's really a team mortality or team morbidity. And it's not just the surgeons. Brad and I remember a time when we were in the hospital, there's no attending in-house. None. And so now the learning curve for all aspects of care, even the ICU, is not well tolerated because, it started with the surgeons and public reporting and probably some elements that are very good for the patients. But now that intolerance of a learning curve is not just for the surgeons, it's for the intensivists, it's for the imagers, it's for the catheterizers. It's the unintended consequences of this is we needed to become, which may be better in the long term, better mentors and figure out how to mentor the next generation of providers so that, but the learning curve never really goes away. We just try to mute its effects. It's not just you guys.
I agree, Brad. This is really an important thing, and I think now we've got newer models of how we can also teach surgeons, younger surgeons, more than that they are actually in the operating room. We are on the left side. We're helping them. You get enough experience, so on. But also we've got simulation. We've got 3D modeling that we could stitch. We get all these videos that are shared now everywhere. So a lot of things have changed in the way we teach surgeons. The problem is obviously transparency works against this, works against innovation, because you're worried about all that. You're worried about being on the STS and so on and so forth. So it is a problem, but I think can be mitigated with mentorship and help in the operating room.
Thank you. Next question. Sure, Justin. Yeah, go ahead.
Yeah. So
Dr. Treader from Cleveland, Ohio.
So we have Dr. Shijong Yu here, who has this excellent hands-on surgical training course with these excellent silicone models. We don't have them here at the conference today, but at the World Congress, if you haven't seen these are the next level of as real as you can get with surgical simulation, and it certainly does it. supplant doing the surgeries in the operating room, but this is, I think, definitely the way forward for surgical training.
Yeah, and Justin is leading a huge surgical sim session at World Congress. It may be the largest congenital heart surgery simulation session ever done, which is going to have all sorts of models and opportunities to practice operations on 3D reconstructed hearts with senior surgeon mentors. And I think that's also going to be part of the future. And we'll see some of that in August. You hold the record for being at the microphone for the longest time.
Thank you for your
the
patience.
floor is yours.
Thank you very
Well,
much.
actually, I'm glad that last question was brought up, but I wanted to switch to one other thing, just the long-term follow-up of the apparently healthy child, adolescent, young adult with arterial switch procedure. So I'm hearing that stress imaging of some sort, maybe every 3 to 5 years with common coronaries, and the high-risk coronary variants maybe every 3 years. Would people like to give their opinion about the best stress imaging modality for the routine follow-up of these patients?
Nick, do you want to comment on that?
Well, in Gainesville, we like to have them stand up in front of a large audience and give a lecture and make sure that the coronary buttons do okay.
Without any beta blocker.
Nick,
Oh, that's funny. So I think the one aspect I didn't discuss is doing a regular old exercise stress test. And I think that's an important part. If you look at some of the studies that have evaluated this, doing multiple types of imaging has a higher ROC curve than sticking to one. And that's typically what we do for our patients. So I think we can't minimize the comprehensive evaluation of these patients. And it's really putting the picture together. And if you look at some of the case series of patients that have had these unfortunate events, some of them will not have ischemic changes on EKG before their event. Some of them will have a very severe coronary lesion and show nothing on their PET scan. So, it's quite variable. So I think it is important to put the entire picture together and not necessarily be prescriptive about exactly when they need to get their imaging, but being able to put together multiple pieces of information and figure out when you have to go to the higher level of imaging to really figure out what's going on and whether they're at risk.
All right, it is 10:17. We want to make sure we respect our break. This is an first session, great discussion. Thank you all for leaning in, and we'll see you in a few minutes. And we'll be talking about TGA VSD and TGA VSD LVOTO. Look forward to seeing you in 20 minutes. 10 minutes, sorry, 10 minutes. No.